Hi, we have come to discuss the hemolytic uremic syndrome part 2. Today we will discuss atypical HUS in this video. So the atypical HUS is it is due to the uncontrolled activation of the alternate complement pathway. It is because of uncontrolled activation of alternate complement pathway. So the diagnosis of atypical HUS is done or is suspected when the HUS is suspected when the Shiga toxin associated E. coli HUS or the pneumococcal induced HUS or the cobalamin associated HUS or the secondary HUS due to infection, when these are excluded. They should be excluded for you to suspect the atypical HUS. It should be based on their clinical and lab features. Okay. So what are the investigation or what are the things you are going to evaluate in a child when you suspect a atypical HUS? So you have to test for C3 complement 3. Second, test for anti-factor H antibodies, flow cytometry for expression of membrane cofactor proteins, that is flow cytometry for CD46, that is the membrane cofactor protein. Fourth, sequencing of complement factor H, complement factor I, complement factor B and thrombomodulin. Blood specimen should be withdrawn for C3 and anti-factor H antibodies prior to your initiating therapy, that is plasma exchange therapy. Next, you have to, if suppose this is positive, that is anti-factor H antibody is positive, then estimate the anti-factor H antibodies level, that is titer, using ELISA. So patients with anti-factor H antibodies, when they have this anti-factor H antibodies, they do not routinely require the genetic testing or do not require screening for genetic variants. So the genetic screening is mainly advised for or advised with when there is early age of onset of HUS, when the child has a relapsing course, or when there is family history of HUS, when the illness is refractory to the therapy with plasma exchange or prior to renal transplantation. These are the conditions in which you will be advising the genetic screening. Okay. This pathogenesis for this atypical HUS is mainly due to uncontrolled activation of this complement, which again leads to the endothelial damage of the glomerular capillaries, that is leading to the thrombosis and platelet and leukocyte aggregation, leading to fragmented RBCs. This is the pathogenesis. The treatment for this here is, mainstay of treatment is eculizumab. It is a C5 monoclonal antibody. Since this is very costly and it is not available in India, so the treatment of choice for us here, it is intensive plasma exchange. Okay, so intensive plasma exchange is the only alternative for us. Start with 60 to 75 ml per kg of exchange. So you the choice of the exchange fluid is FFP, fresh frozen plasma. So these are administered daily. Until there is a hematological remission. Until there is hematological remission. So when you call it as a hematological remission is when the platelet count, so platelet will be the first to recover in the HUS. When the platelet count is more than 1 lakh, when the cystocytes are less than 2% and the level of LDH. So when the level of LDH is less than upper limit of normal for 2 consecutive days. Then you stop this plasma exchange. Okay, then this is tapered over 4 to 6 weeks. This is for the patients with atypical HUS, but atypical for the patients with anti-factor H antibody associated HUS. So the patients, because in India the pediatric HUS, that is atypical, pediatric atypical HUS, here anti-factor H antibodies constitute about 50% of pediatric atypical HUS. So for the patients with this, you give a combination of plasma exchange and immunosuppressive therapy. Okay, for immunosuppressive therapy, before starting this, you need to confirm whether the patient is having anti-factor H antibodies or not. You will give prednisolone at the dose of 1 mg per kg per day for about 4 weeks. Then it is tapered for alternate day. Then you are tapering it over 10 to 12 months. Okay. While doing this, you should check for antibody titer level. Antibody titers should be sequentially measured for about 12 to 24 months during the follow-up. If the titer level is more than 1300, when it is more than 1300 AU is arbitrary units per ml, there is a high risk of early relapse. High risk for early relapse. Okay. What are the other immunosuppressive therapy, or what is the sequence of the therapy? I will show it to you. So this is for atypical HUS. So you do a daily plasma exchange within 24 hours of diagnosis, because to stop the irreversible renal damage, you are doing this daily plasma exchange within the 24 hours of diagnosis. When there is an elevated anti-factor H antibodies, so you are doing this for about 5 to 7 days, then you are tapering it over 4 weeks to 6 weeks, you are tapering it. When you consider eculizumab is when there is a life-threatening or it is a refractory illness, or when there are complications of the plasma exchange, you consider this eculizumab. Okay. Next, along with this, you are giving a oral prednisolone at the dose of 1 mg per kg per day for 4 weeks. Then you are going to taper it. When the child have an hematological remission, so I have told you the hematological remission is when the platelet count is more than 1 lakh. When the platelet count is more than 1 lakh, when the cystocytes is less than 2%, and the LDH level is less than upper limit of normal for 2 consecutive days, for 2 days. Okay, then it is called as hematological remission. When the child is having a hematological remission, then you give a cyclophosphamide at the dose of 500 mg per meter square for about 4 weeks. Preferably 5 doses. Give it weekly once. Then you taper the plasma exchange. Next, when you are doing the follow-up, when the child presents with the chronic kidney disease stage 1 to 3, you are giving prednisolone at the dose of 0.2 to 0.3 mg per kg on alternate days for about 12 months along with mycophenolate mofetil or azathioprine. Or if the child has a CKD of stage 4 and 5, you will withdraw immunosuppression, give a supportive therapy, and you do a genetic study because you are planning for a renal transplantation. Okay, this is about the flow chart for atypical HUS management, or when the child is refractory, that is no hematological remission despite 7 to 10 days daily of plasma exchange. Then you consider combining plasma exchange with eculizumab. Then you consider genetic testing for additional defects. Then check antibody titers. If high, then you increase the plasma volume and plasma exchange frequency. Okay, this is about flow chart for the atypical HUS treatment chart. Okay, next I have to show you what is the difference between Next, I will show you the difference between the remission, relapse, and this refractory to the treatment. So, in this, I have told you for the remission. For relapse, it is recurrence of anemia with cystocytes of more than or equal to 2%, elevated LDH, and with thrombocytopenia with or without AKA, following remission for more than 2 weeks. After 2 weeks of being in remitted phase, the child again has a recurrence of this anemia with cystocytes or elevated LDH and thrombocytopenia. It is called as relapse. That is relapse. Next is refractory illness. When despite the 7 to 10 days daily of this plasma exchange, the child, there is no improvement in the platelet count or persistent hemolysis, it is called as the refractory illness and relapse. Okay, this is the definition for remission, relapse, and refractory illness in a child with the HUS. Next, we will see the prognosis for everything. Prognosis is mortality rate for diarrhea associated HUS. So, mortality for diarrhea associated HUS is less than 5%. First, platelet count increases. Next is the renal recovery. Third is resolution of anemia. Okay. Third, for pneumococcal associated HUS, there is more than 80% of the patient require dialysis with 20% of mortality. In the previous video I have told it as 30%, sorry, it is 20% of mortality. This is about the prognosis. Okay, this is about atypical HUS, treatment for atypical HUS.